Okay, Siris, I'm visible and my slides are audible. I am audible and my slides are visible.
Yes, sir.
Yes,
Okay.
sir.
Okay. So I'll be talking about the anterior neck, lateral, and then posterior neck. So let us learn the muscle there, and then we'll be talking about the recording has started, Siris.
It has started, sir.
Okay. So anterior neck, if we are removing the platysma, and then there are very small, thin strap muscles. If you're starting from the midline, so remember, will be home page in the anterior neck is at the level of the cricoid cartilage, C6, Cassinex tubercle. That is our home page. So almost always will be again when start the scanning, will be starting at the level of the C6 only. So if you are holding the probe there, from the midline, we are having the few strap muscles, very thin of the strap muscles. So most medial is your sternohyoid. And if I'm removing the sternohyoid, then just below and little lateral is your sternothyroid. And lateral to that is your omohyoid. Omohyoid is again having the superior belly and one is your inferior belly. Let me remove, and on the side of that superficially is your sternocleidomastoid. So I'm removing the sternocleidomastoid so that you can understand it. So you can see this is the omohyoid muscle, this is the superior belly, this is the inferior belly. And just medial to that is your sternothyroid, and above that, what I have already removed was your sternohyoid. So now, below the sternocleidomastoid, we will be having the scalene group of muscles. So scalene anterior here, then your scalene middle, and the scalene the levator scapulae, but just above another is the scalene posterior. Scalene is posterior and scalene mid, the levator scapulae is almost together. Many a times it is very difficult to differentiate between these two. And last, superficial most one of the muscle here, but at the level of the C6, if you are going laterally, the muscle here is bulky. When we'll be talking about the posterior neck, the trapezius will be very thin layer of muscles, but at the level of the C6, trapezius is quite bulky muscle. So these are the muscle layers we'll be seeing one by one. And then we'll be, let me put the vessels and the knobs now. So vessels, important vessels, veins, and nerves. Okay. So now what I'll do, I'll be removing the muscles for the better understanding. So sternothyroid, if I'm removing the sternothyroid, one of the muscles below will be coming your longus colli muscles. So longus colli muscle is very important because above the longus colli muscle, we need to give the stellate ganglion block when we are doing under the CM guidance. So if we are holding the probe at the level of the C6, that means at this level, we will be able to see the thick anterior tubercle. Let me do one thing. Let me remove all the layers first one by one. Let me talk about the bones and then we'll be talking about the other things in detail. I've talked about the muscles. Remember the muscles? Let me talk about the bone also because... Okay. So what I was talking, that this was C7, this was C6. So all these, how to understand this C6, the most important when you are taking the home page, that it is having a big anterior tubercle. So this transverse process has the anterior tubercle and the posterior tubercle. So the highest anterior tubercle is at the level of the C6, and you can palpate it with our fingers as well. The C7 anterior tubercle is very much rudimentary. And at other levels, when we'll be going up and up and up, then the anterior tubercle will be getting diminished and anterior posterior tubercle will be almost of similar. And if we are adding the nerves now, so all this, when you're seeing the cervical nerves, cervical nerve roots, so all these will be having the different nerve roots. So the transverse process here, this will be a C6. So this will be a C6 nerve root. This will be a C5 nerve root. This will be your C4 nerve root. In that way, you have to remember what? In the cervical area, the nerve root, same level nerve root comes just above it, above through the above the transverse process. And also another nerve root cervical 8 is there, which is also visible and which will be below the C7. So if we are going above, we'll be starting from the C6. We'll be able to identify the each nerve root if you are going above and also below the two nerve roots C7 and C8. At the level of the C3, it is easy to identify because here the carotid artery, which was there, let me put the carotid artery there. Carotid artery bifurcates here. See, the bifurcating at the level of the C3. So this is 7, the 6, 5, 4, 3. So at this level, it gets bifurcated. So when we'll be seeing that the carotid artery is no longer one, it has been bifurcated, then you understand that this is the C3 level. So we'll be able to identify these nerves, and also another nerve which goes just lateral to the carotid artery is the vagus nerve. Vagus nerve also is very nicely visible between the jugular vein and the common carotid artery. You'll be able to identify the vagus nerves. And another important artery here, this is your vertebral artery. This is very dangerous artery. So it originates from the subclavian artery. And you see, let me remove the carotid artery. So here, try to understand the anatomy of the vertebral artery very nicely. The vertebral artery lies anterior to the C7 transverse process. And it goes within the transverse process of others. At the level of the C6, it is within the transverse process. At the level of the C7, it is open. Why it is important? Because when you are doing the stellate ganglion block, stellate ganglion, where it is situated? It is situated at the junction of the transverse process in the vertebral body at the level of the C7, T1 and adjacent disc. That means at this level. So classically, the stellate ganglion block is done at the level of the C6 tubercle. When we used to do it blindly, then we used to put the needle here at the C6 tubercle. Let me enlarge it a little bit. So when we used to do blindly, we used to put it this anterior tubercle of the C6. So what is the advantage there? Advantage is vertebral artery. If you are touching the bone, feeling the bone here, and if you are giving it, then the chances of puncturing and injecting into the vertebral artery is much less. If you are coming at the level of the C7, the vertebral artery is all open. And another artery, which is not seen here, I can put it there, is your inferior thyroid artery. Inferior thyroid artery, let me put. So this is your inferior thyroid artery. So this inferior thyroid artery, it goes posterior to the common carotid artery, and that is also at the level of the C7. So in the C7, the two vascular risk. One is your vertebral artery and vein. Vein is also there just beside the artery. So you can inject vein also. Let me put the vertebral vein also. So this is vertebral vein. So the vertebral artery and vertebral vein, these two are important danger. And by the side of that, here also at the level of the C7, we are having the inferior thyroid artery. This is also a problem which crosses just posterior to the common carotid artery and goes to supply the thyroid. So these vascular structures are there, which is very dangerous. But fortunately, when we are doing the ultrasound, we can identify all these structures. So before giving the stellate ganglion block, you must be aware of all these blood vessels, vertebral artery and vein, and inferior thyroid artery. Apart from that, carotid artery is also there, jugular vein is also there. So you have to take care of that. And for a good important success, we have to remember the longus colli muscle is there. Let me put the longus colli muscle now. Longus colli muscle, if you are putting this, so this longus colli muscle is there. So if we are hitting the bone and giving over the bone, then there is a chance. Let me remove this one so that you can understand it better. So the longus colli is lying over the transverse process. So longus colli muscle, stellate ganglion is situated above that, anterior to that. So you have to identify the longus colli muscle and you have to inject above that. If you are giving the stellate ganglion block blindly or under the CM guidance, then chances of failure is there because of this longus colli, which many times we inject within the longus colli muscle. So these are the advantage of the stellate ganglion block under the ultrasound guidance. So nowadays, ultrasound guided stellate ganglion block is the standard. That is how we should do it. But if you are doing under the CM, then you should be very cautious. At the level of the C7 also you can give. But remember that at the level of the C7, we are unable to identify the blood vessels. I told you 2-3 important blood vessels are there, which might be, you might be puncturing those blood vessels. Particularly of concern is your vertebral artery, which is anterior to this. So this is your little bit about the anteriorly. Now, if I'm going laterally, few things is important. One of them is your let me bring it there. Laterally, few things are important. One of them is your facet joint. So facet joint, nowadays intra-articular facet joint injection is not done. And you look at here, the joint is at heel and median nerve lies here at this valley. So this heel and valley, when you're seeing at the CM or at the ultrasound, we'll be able to identify this heel. At the heel top, we are having the joint, and the valley from where you have to target for the medial branch block. So this also you have to remember in the lateral part. And lateral part, another important thing is there. Let me put the nerve and the muscle. So that is your superficial cervical plexus and few of the nerves of the superficial cervical plexus. So if you can recall, what are the nerves of the superficial cervical plexus? Superficial cervical plexus is originating mostly from the ventral rami of C2, 3, 4. Little contribution may come from C1 also, but mostly C2, 3, 4. So they are the ventral rami branch. And what are the branches? The most important, what is our concern, is your lesser occipital nerve. So this is the lesser occipital nerve. Remember, this is under the sternocleidomastoid. If I'm removing the platysma, let me remove the platysma. So this is the sternocleidomastoid muscle. Below the sternocleidomastoid muscle is the superficial cervical plexus, which is formed by the ventral rami of the C2, 3, 4, and three important nerves are coming. One going as a V-sepate along the posterior border of the sternocleidomastoid is your lesser occipital nerve. So what is the root value of the lesser occipital nerve? C2, 3 anterior rami. As I told you, 2, 3, 4. So 2, 3 is your root value for this lesser occipital nerve. Remember that. Then is this is a V-sepate. One of the V, posterior part of the V is your lesser occipital. Anterior part of the V is this nerve is the greater auricular nerve. It wraps around the sternocleidomastoid muscles from posteriorly, goes anteriorly, and goes towards our tragus. And below these are the two nerves. What are these two nerves? So again, inverted V here. It put up. So one is your supraclavicular nerve. This one, supraclavicular nerve, which goes towards the clavicle and supplies the skin and the upper part of the superior part of the shoulder. So if you're asking that the superior part of the shoulder, which nerve supplies, that is your supraclavicular nerve. And another your transverse cervical, this one, which runs anterior, transverse cervical. Okay, this one. So the transverse cervical. So that means these are the two V, one inverted V, and above these are the two V. And this, particularly as I told you, our concern is this one and this one for the headache and the pain. So you should be many times you need to block the lesser occipital nerve. Now come to the posterior. Posterior is again very important, little complex, but again you have to remember the different muscle layers, and then we'll be able to identify, understand what are the nerves there in between the muscle layer. So one is this muscle is your trapezius. As I told you, trapezius, where it is inserted at the occiput, is a very thin layer, like a strap muscle. So let me remove it. If you are removing it, then it's a big bulky muscle here. This muscle is your semispinalis capitis. So semispinalis capitis is a very big muscles, the midline, and it lies just below the trapezius. Trapezius is a very thin strap muscle. And lateral side is the splenius capitis, this muscle. This is your splenius capitis. So if I'm removing this semispinalis capitis and the splenius capitis, I'm removing this, then few small muscles comes out below this. One of them, this one, is your rectus capitis posterior minor, this one, which is from C1. Let me now increase, magnify it. So this muscle is your rectus capitis posterior minor. So this is from C1 till occiput. And another muscle which is oblique from the spinous process of the, this is spinous process, bifid spinous process of the C2. From here it is going to the occiput obliquely. This is your just side of that is your rectus capitis posterior major. So this is your rectus capitis posterior major. And from C2 to the transverse process of the, this is a, let me remove the knob, then we'll be able to understand it better. Okay, so, and also let me remove the blood vessels, just muscles and artery. I'll be adding some of the arteries are important. Okay, so this was your rectus capitis posterior minor, this was your rectus capitis posterior major, and from the C2 spinous process, this bifid spinous process, this muscle is very, very important for us. This runs obliquely, and you see that this is almost along the whole of the lamina of the C2. It lies over the lamina of the C2, originating from the C2 spinous process, lamina of the C2, and getting attached at the transverse process of the C1. And from there, this is your rectus capitis, your inferior oblique muscle, and this is your superior oblique muscle. So this is your the obliquus inferior or inferior oblique, which is starting from here and going. Why this muscle is important? Between this muscle and above that, what was the muscle? Medially, we was having the semispinalis capitis. So between these and the semispinalis capitis, we will be able to find out two important, let me put the nerves and vessels now. So two important nerve will be coming here. One is greater occipital, another is your third occipital. So greater occipital root value is what? It is the continuation of the, where is the nerve? Okay. So two important now. One is your, this was your, the greater occipital nerve, and another is your lesser occipital nerve. Lesser occipital, what is the root value? It is the continuation of the dorsal rami of the C2. And lesser occipital, it is the dorsal rami of the C3. Continuation of the dorsal rami of the
third occipital, sir.
Third occipital. Third occipital is a continuation of the dorsal rami of the C3. So C2 and C3, and they lies over this inferior oblique muscle. And in between these two muscles, these two nerves, there will be one artery pulsating. You'll be able to see that. That is the continuation of the deep cervical artery. So if we will be holding the probe in this axis, we'll be able to see these two nerves on the either side, and there will be the pulsating blood vessels, that is your deep cervical artery. So this area is very, very important. And if you're going laterally, then this was your sternocleidomastoid, and posterior to the sternocleidomastoid, this nerve is what now? Tell. Just now I told.
Lesser occipital. Lesser occipital.
And this one your
Greater auricular.
greater auricular. It is the V separate, two part of the V, one posteriorly and one anteriorly. This is your branches from the superficial cervical plexus. Okay. So these are the structures which will be demonstrating. Now, if you want to see anything else from the 3D anatomy, I'll be showing, and then our volunteer is ready. So we'll be starting scanning. Anything else you wish to see it again? Nothing? Okay. Then let me. Okay, so today also you're having two cameras, so that we can appreciate the structures better, particularly holding the probe. So all of you can see the volunteer neck nicely.
Yes, sir.
Okay, one little bit closer and a little bit. So the probe will be linear, high frequency linear. I'll start scanning from the anteriorly, and if you can remember, what was our home page anteriorly?
Cricoid cartilage.
Cricoid cartilage and C60 working. So, I can palpate the cricoid cartilage and go there, or I can just scan it and you can see the anterior tubercle. You can see this anterior tubercle. Can you appreciate the anterior tubercle? At the middle of my screen, something projecting up.
Sir, please can you freeze it and marking every details?
Okay. So you can see something projecting there. Let me. Can you appreciate it? I'm just removing it and try to understand. So this is a bony shadow. You know why bony shadow? Because I can't see anything here. I can't see anything here. That means this is a bone. So this is the bone. So this is the transverse process. On the side, we are having the anterior tubercle. This is anterior tubercle, and this is the posterior tubercle. And something black rounded things coming out. One is already coming out. This is C5 nerve root, and this is your C6 nerve root. Why this is C6? Because we are having the big, large anterior tubercle. And another very important thing, which is you can see some hypoechoic structure here starting here. This is your longus capitis muscle, which gets attached. Longus capitis muscle gets originating from the different anterior tubercles of this the spinous process of the transverse process. But last one is because the anterior tubercle is not there in the C7. So the last muscle fibers, which is getting the longus capitis is muscle is this one. And apart from that, what else you can see? We can see the carotid artery, jugular vein. Okay. So can we appreciate this page, home page? From here we'll be starting and we'll be looking for one after one all the structures. And
Sir,
because
jugular vein, where here in this picture, please?
what?
Jugular vein.
Jugular vein. Okay. Jugular vein is this one is jugular. This is carotid artery. This is jugular vein. This is longus capitis muscle. I'll be showing all the structures one by one. First, I wanted to tell you that this is our homepage. Identify at this picture. I am just asking you to see, identify this one. All other structures I'll be showing you much more clearly. First, at the middle of the screen, this is your anterior tubercle. Just try to don't miss it. Just scan little up and down and try to identify the anterior tubercle. And if you see the hypoechoic area, these try to identify this also. That is your longus capitis muscle. If the longus capitis muscle, you can find it out from the tip, you understand this is C6. If you are going down, then you will no longer be finding this longus capitis muscle. Okay, all of the structures I'll be showing you one by one. Just try to identify and don't miss it, this one. Okay, here now?
So your aspect marker is towards medial side.
Aspect marker is towards the lateral side. This side is aspect marker. This is lateral side, this is medial side. This is lateral side. Okay, this is the transverse process. Here is the trachea, this is the thyroid, and this is carotid, this is jugular, and I'll be showing you all other structures. Up to this is clear? Okay, I'm showing you again, don't worry. Any number of times. Okay, I'm unfreezing, I'm showing you. So, what I was telling you, I'm just going up and down to find out the SNX tuber. So this was the midline, the trachea. And this is, you can see the jugular vein and carotid artery. Can you appreciate that nicely? And the transverse process. But I am not able to see you see something coming out black. That is what I was searching at this point, this one. At the middle, something projecting out with a cap on it. That is your longus capitis. Can you appreciate that? Yes or no? So at the middle of my screen, exactly the center of the screen, some triangular black shadow is coming up.
Yes, sir.
So what is that?
It's an anterior tubercle.
That is the anterior tubercle. And by the side of that, so this is your anterior tubercle. And what is coming out, this black, very big black, this is posterior tubercle. What is that? Is your C6 nerve root. You see how nicely it is coming out? Can you appreciate this C6 nerve root? Can everybody appreciate a C6 nerve root? Vanishing within. Everybody can appreciate. So this was your anterior tubercle, this was your posterior tubercle, and in between the C6 nerve root is coming out. If I'm bringing my probe down, see the C6 nerve root is very nicely coming out, and this muscle is your anterior scalene, this muscle is your middle scalene, and it is going in between the two scalene. Now, if I'm coming down, look at here. So now what will happen? Now the C7 is coming out. This is your C7, and as I told you, C7 has the posterior tubercle, no anterior tubercle. But nerve root is coming here. This was your C6. This nerve root what is coming out is your C7. You can see C7 just above the C6. C7 transverse process is your C7. So the nerve root what is there? C7, C6, C5. And if I'm coming still down, the another nerve root will be coming. You see, this is another nerve root is coming. That is your C8. That is below the C7 transverse process is your C8 nerve root coming and going there. So all these nerve root are going there in between the two scalene muscles. This is the anterior scalene, this is the medial scalene, and there is the different nerve roots coming out. Is it clear to everybody? If you say yes, then I'll be going deep about the other thing. So I started from here. This was your.
Here, please freeze it and by pen marking it, please.
Something, what you are telling, that is true, but at the same time, you have to understand some scanning. This is ultrasound. This is a dynamic scanning. You have to understand the dynamic scanning. Otherwise, you will not be able to appreciate it. Okay, I freezed it here, and I'm holding it nicely here and try to understand what is there. This is your what? Just now I told. This is anterior tubercle. And what is this black shadow here?
Longus coli, sir.
Longus capitis.
Longus capitis. And if you see, when I'm coming down, this longus capitis is vanishing. No longer longus capitis is there. I'm keeping the longus capitis in the center of the skin. I'm coming down, longus capitis is vanished. Longus capitis is here. And if I'm just follow this, it will be getting bulkier if I'm scanning it above. You see, the longus capitis is becoming bulkier. This is your longus capitis. So now I cannot freeze it, you have to understand the dynamic scanning. So this is your longus capitis. This is your longus capitis. If I'm going above, that is longus capitis. And this is your longus coli. Below that is your longus coli. So now if I'm coming down, so this was our home page. This was your anterior tubercle. So this was your longus capitis, and this was your longus coli. And this was your jugular vein. And what I was trying to show you, all the cervical nerve roots. So this nerve root was C6. Then I'm coming below, that is your C7 coming out. This is the transverse of the C7. If I'm still coming out below that, another nerve root is coming out, that is your C8. This is your C8. So now let us see the other nerve roots above. So this was your C6. Anterior tubercle is peeping out. Longus capitis muscle has started. If I'm now going above, slowly, above. Now another, you see, another tubercle is coming out. That is your C5. So nerve root, what is there is your C5 nerve root. This was your C5 nerve root. Then I'm going above. This was your anterior and posterior tubercle. And here you see anterior posterior tubercle almost of equal height. Can you appreciate? The C5 nerve root is going inside. Everybody at the center of my screen.
Yes, sir.
Okay, now I'm still going above. Another nerve root is coming, that is your C4. Carotid artery is still down, dancing and still single. So this is your C4. If I'm still going above, look at the carotid artery. Now carotid artery is getting divided. Can you appreciate the carotid artery is getting divided now? It is becoming 2. So at this level, the nerve root that is coming out is your C3 nerve root. Here the carotid artery is 2. This is your C3 nerve root. Okay, this was your C3 tubercle. So anterior and posterior tubercle is almost, posterior tubercle is now a little higher than the anterior tubercle. So this nerve root is coming is your C3 nerve root. And From coming below, this was your C4 nerve root coming out, anterior posterior tubercle. Then I'm still coming down. This is your another nerve root is coming here. Anterior posterior tubercle is almost equal, anterior tubercle is slightly larger. So this nerve root is your C5 nerve root. And now this is your big anterior tubercle. This nerve root is your C6 nerve root. And still coming down, now there is no anterior tubercle, only posterior tubercle. This is your C7 nerve root. And still coming down below is another nerve root is coming out. This one, this is your C8 nerve. Okay, everybody understood this, the nerve roots, cervical nerve roots?
Yes, sir.
Yes. So now another thing you have to understand. So I'm just giving some color there. Color sometimes it is not accepted, but still. So the nerve root normally accompanies some blood vessels there. So if you are going to inject the nerve root, be aware of the blood vessels there. So this is the nerve root. I'm putting it in the box and I'm searching for the blood vessels. The black things is basically blood vessels. Sometimes you do not pick up color. Very tiny black dots beside it. I'm freezing it. So this was the nerve root, and just beside that, there is blood vessel, which is accompanying the nerve root. So be aware of those nerve roots. So when we are injecting. So now, what we have seen here is the nerve root. Now I'll be going to the stellate ganglion. So our home page was here. Here was our home page. I'm just extending the neck a little bit more so that you can appreciate the structures better. So this was at the center is your C6 tubercle and C6 nerve root. And on the medial side, again, let me freeze it. So this was your longus colli muscle. This was your longus colli muscle. This was your longus capitis muscles. This is anterior tubercle, posterior tubercle, and carotid artery, jugular vein, vagus nerve, and this was your anterior scalene muscle. This was your posterior scalene muscles. These are the nerve roots which is coming out. This was C6. This was C5. So now, at this point, what is important? Classically, this was your thyroid. Okay, I forgot to describe the few of the strap muscles there. Okay, I'll be describing that. Before that, let me talk about the stellate ganglion block. So stellate ganglion block, classically, we used to inject like this. Needle can come from here and just medial to the Cassinix tubercle. When you used to do it blindly, we inject here. When you used to inject it under the ultrasound, under the CM guidance, how you used to inject, you come perpendicularly, hit this transverse process, withdraw the little bit. It is medial to the carotid artery, withdraw a little bit above the longus colli muscle. This is the longus colli muscle. The longus colli muscles you inject here. But as I told you, that this is C6. Stellate ganglion is situated from the C7 and T1. So you have to give large volume, expecting that it will be trickling down and the stellate ganglion block will be done. But nowadays, what we do, we go directly at the C7, and for there, we are having some of the dangerous structures which you need to identify before giving the injections. I'll be showing you those structures. So, again, so home page. So this was the home page. Anterior tubercle, large anterior tubercle, and the C6 nerve root is coming out. So at these positions, longus colli muscles just below the carotid artery, jugular vein, you can see, and the vagus nerve also in between the jugular, this on the top, in the middle between the jugular. This is your vagus nerve. Okay, so now from here, just look what I'm doing. Can you see some structures just at the C? You know, I'm keeping it in the below and I'm putting the color there. I'm putting color here. This is the, you see, here it's fine. Just I'm coming down, some color, some vessels are coming, and that is your vertebral artery. Again, I'm removing it. So just try to appreciate it. This was your anterior tubercle, posterior tubercle, home page, transverse process, very nicely seen. So now, if this was your anterior tubercle, posterior tubercle, C6 nerve root, transverse process, longus colli muscles, longus capitis muscles, jugular vein, carotid artery. So now, if I'm sliding down, you see some artery is pulsating, and beside that there is some vein. Just try to understand that. And that is your vertebral artery. You follow this vertebral artery. Now this is C7 is coming below. And vertebral artery is anterior. Can you appreciate this? Something pulsating.
Yes, sir.
Something pulsating here. That is your vertebral artery. And if I'm following it, see what is happening. It is getting originating from the, this is your subclavian, you know, the below this is coming is your subclavian. So vertebral artery originates from the subclavian. So this is the vertebral artery going above the C7 transverse process is the C7 transverse process. This is C7 transverse process. And you can see the pulsating blood vessels on the top of it is your vertebral artery. And look another things. Look at the carotid. Can you see something is passing? Some black structures. Can you just below the carotid artery? I'm just toggling it little bit above and down, and some
Sure.
stuff. So that is your inferior thyroid artery. So this is also a danger when you are doing it. Can everybody appreciate the inferior thyroid artery? Okay, let me again put the color so that let me put the color there. So that is your inferior, just below the carotid artery, that is your inferior thyroid artery. This artery, this one, going horizontally. That is your inferior cervical. So if we are doing it at the level of the C7 here, so what are the, this is C7 transverse process. I'm changing it now here. So the C7 transverse process, the C7 transverse process, rudimentary posterior tubercle. So this is your longus colli muscle. Okay, so you have to inject it here, but again you have to take care that you are not punctured. This is not the right view how to inject. I have given just, this is your inferior thyroid artery. Here is your the vertebral artery and vein. So these are the structures which is very dangerous, and you have to come here or come here, and you have to inject there above the longus colli muscle. Here the success rate will be increasing, but we have to take care of these two vessels. One is the vertebral artery vein, and another is your inferior thyroid artery. Everybody has appreciated. I'm showing it again. I'm showing you one space where you can inject it. So this was your inferior thyroid artery going below. So, and okay, so you should not be injecting here. You can inject here or inject little down the longus colli muscle. When the inferior thyroid artery is not in your field, inferior thyroid artery has moved on lateral. So here you can inject above the longus colli muscle. Okay, everybody appreciated the two approach. One is classical, which where the injection is done at the level of the C6 anterior tubercle, and another which is more recent, that is injecting in front of the longus colli muscle at the level of the C7.
Can you show it at the C6 level once again?
C6 level. This is the anterior tubercle. So here, this is the longus capitis muscle, this is the longus colli muscle. So you have to inject here above the longus colli muscle. You can come it. You can come it from either from here, or you can come it through here, or you can come it from here above the longus colli muscles. Normally, the drug will be spreading around it, and it will be covering the skeletal block. But here at this level, if you are blocking, you have to give larger value. But this area is safer because important arterial structure, vertebral artery, inferior artery is not there. Jugular vein, can you puncture jugular vein to give the injections? Answer is yes. So you can puncture, you can go through and through the jugular vein, and you can go beyond. You have to see the needle tip. It should be done in plane, and you can inject it below, puncturing through the jugular vein. You can go there and you can inject it. Okay, or you can come through the thyroid, medial to the carotid artery, and above the longus colli muscles. You can inject here, you can inject here through the jugular vein, or you can come lateral to the jugular vein. So there are the few approaches, or here you can come between the jugular vein and the carotid artery. Understood? So you have to inject in this plane, this area. Right? Stellate ganglion cannot be seen by the ultrasound because there is a thin plexus of the nose. It is not appreciated. So now,
Sir, injecting about 10 cc volume is good.
volume, if you are injecting at the level of the C6, then your volume should be around 8 to 10 cc. But if you are injecting at the level of the C7, then 4 to 6 cc is enough. Okay?
Okay.
So now I forgot to mention some of the muscles there. So this was your cricoid area. Not cartilage is not nicely seen here, but you can see all the muscles there. So what he told there, the superficial most muscle, this is your what muscle? Sternocleidomastoid. Below that, sternothyroid, and here is your omohyoid. I'm just showing you again. So at the level of the, if you are at the level of the C6, this is at the level of the C6. So you can see these strap muscles. So most medial, okay, let me show you again. The most medial, this one is your sternothyroid. Below that is your sternothyroid. And if I am going little more laterally, I'll be seeing the omohyoid. Again, let me show you. So here is your sternothyroid and sternothyroid, and this lateral one is your. So here I can see it, all the layers very nicely. So this was your sternothyroid, sorry. This was your sternothyroid. This is your inferior belly of the omohyoid, and this is your sternocleidomastoid. Everybody could appreciate it? All the small layer of the muscle. I removed it. So these two muscles, sternothyroid, sorry, above one, most superficial is your, this one is your sternothyroid. This is your sternothyroid. This is your omohyoid. Here, don't forget, again I'm showing you. So you can see sternothyroid, sternothyroid, omohyoid, and now sternocleidomastoid on the middle, on the superficial most. Sternocleidomastoid has two heads, the sternal and the clavicular, and I am going laterally. So you can see here the scalene muscles also you can see. So here, if I'm seeing here, the nerve root, C6 nerve root, C5 nerve root. So this muscle was your scalene anterior. This muscle was your scalene posterior. This was your sternocleidomastoid. So now if I'm going more posterior, here it will be coming the middle posterior scalene. Here it will be coming levator scapulae muscles, and here it will be coming your the trapezius muscle. So just when I'll be sliding there more posteriorly, you'll be able to see these muscles also. So let me start again. So from here I am starting. So you can see sternothyroid, sternothyroid, sternocleidomastoid. Below that is your omohyoid. You see, omohyoid is gliding above the jugular vein. Just above the jugular vein is omohyoid. Omohyoid is oblique. This is the inferior belly. And then if I'm coming more laterally, so this was your the anterior scalene, this was your middle scalene. If I'm going more posteriorly, so this was your sorry, let me remove the drawing. So if I'm going more posteriorly, this is your levator scapulae muscle. Levator scapulae. This muscle is levator scapulae. And if I'm going still posteriorly, then this is now what is coming is your trapezius. Now this is your trapezius. This muscle is your trapezius. This is your levator scapulae, and this is your the posterior scapulae. This muscle is the posterior scapulae. Okay, so these are the muscles in the anterior neck. Let me show you again. Starting from here, sternohyoid, sternothyroid, omohyoid, sternocleidomastoid. Below that, anterior scalene, middle scalene, brachial plexus nerves are coming, nerve roots are coming between these two. Then, if I am going more posteriorly, this is your levator scapulae, and still there it is your sternocleidomastoid. Okay, now if you wish to, okay, I forgot. Sorry. I forgot to show you the disc. This can be seen by anterior view and vertebral artery in the long axis. So, for that, I have to show the long axis. So here, what I am showing again. Let me come to the home page. Home page is what? Try to find out the anterior tubercle, large anterior tubercle. So this is a large anterior tubercle. I am keeping it in the middle of the screen. So this is at the level of the C6. Everybody can appreciate it. I'm sure. This is your large anterior tubercle, longus capitis muscle is seen. So I'm keeping this anterior tubercle in the center, and now I'm doing it in the rotation. The aspect marker is now on the cranial side. Okay. So now what you can see here, this is your C6 anterior tubercle. This is your C5 anterior tubercle. This is your C4 anterior tubercle. And this muscle is your longus capitis muscle. As I was telling you, longus capitis muscles are getting attached. Some fibers is getting attached here, some fibers is getting attached here, some fibers is getting attached here. It gets attached with all of the anterior tubercles. And another very important thing what you have to understand here in this view, is your vertebral artery going below. So let me put the color there. Sorry. I have to remove the aspect, the drawing option, then only I can. I was here. Now I'm putting color there. See, this is your vertebral artery. So when I am over the anterior tubercle, then I cannot see the vertebral artery. I cannot see. But if I'm going above and below, that is your vertebral artery. That is your vertebral artery. So vertebral artery is running longitudinally. So this is the vertebral artery going longitudinally. This is your anterior tubercle, C6, C5, and this was your longus capitis muscle. Now, if I'm going more medially, you see what is coming here. So I'm freezing it here. So let me draw. This was your C6 vertebral body, anterior vertebral body. This was your C5. This was your C4. So this is your C6, 7 disc. This is your C5, 6 disc. This is your C4, 5 disc. So this is one of the options. This is one of the ways in the cervical area you can think of doing a discography or disc procedure under the ultrasound guidance also. So let me remove it and let me show you again. So my aspect marker, left hand side is your the cranial side where I'm having the aspect marker. And okay. So unfreeze. So I was here. So this was the C6 tubercle. That will be telling you at which level we are. At the middle of my screen is C6 tubercle. So if I'm going medially, then the vertebral body what is coming is your C6. So in the middle of my screen, the vertebral body is your C6. And I can see the disc space between the C5, 6, C6, 7. And you can see this is your C4, 5, this was your C5, 6, this was your C6. Okay, understood? So anything you will see in the anterior neck. Otherwise, I'll be going into the lateral neck and then posterior. Okay. Nothing? Let me go to the lateral neck. Lateral side, very important is the superficial cervical plexus, and I'll be showing you the greater auricular nerve there. So again, where to search? So we have to search the posterior border of the sternocleidomastoid muscle. So sternocleidomastoid muscle is here. So we demonstrated it the posterior the sternocleidomastoid. So this is your sternocleidomastoid muscle. So I'm going posteriorly. So this is the posterior part of the sternocleidomastoid muscle. And beside that, what muscle which will be coming, as I told you, this is the levator scapulae muscle. This is your sternocleidomastoid, the trapezius muscle. So now, if I am searching there, just let me reduce the depth now. That will be showing the. Okay. So now, if I am going above and below, can you see some nerve is coming? This one I'm talking. Look at that. If I'm coming, so it is going below. So superficial cervical plexus is here. 4 important nerves will be coming there. If I'm going above, you see this nerve is appearing and then wrapping the posterior border and then going anterior to the sternocleidomastoid. So this is your greater auricular nerve. This is your greater auricular nerve. I'm keeping just below the yellow marker. It is coming down, and it is wrapping around into the cervical plexus. This is your greater auricular nerve. And if I'm coming down, there are 2 other nerves are coming down. One is going posteriorly. This one. This nerve is your spinal accessory nerve. This nerve. And another nerve which will be running from the posterior border will be your lesser occipital. The nerve on the posterior border is your lesser occipital nerve. This is your posterior border. You search it here. Find it here. So one nervous structures which was below the sternocleidomastoid, this one, and then running around the posterior border. I'll be showing this lesser occipital nerve from the posterior as well. Okay, so this is your superficial cervical plexus. Now I'll be making the patient prone and I'll be showing you the facet joints and the occipital nerves also. Greater than the.
So,
Yes.
sir, the nerve which is winding around the posterior border of sternocleidomastoid is greater auricular? Or
The nerve which is going starting around and going anteriorly is your greater auricular, and which is going straight without wrapping around is the lesser occipital. Okay.
thank
What
you.
is it again? Okay,
Yes, sir, occipital I would like to see.
Hard occipital I'll be showing in the posterior. Huh? But still, you can appreciate a little bit here as well. So what we have to do, we have to search it here. So can you see this nerve? This nerve is your greater auricular. Why? Because this nerve is wrapping around like this and going here. When I'm toggling, I'm coming down. You see, from here it is originating. And it is wrapping around and going there. Going anterior. This is anterior side. This is posterior side. So this nerve was coming like this and going in this way. Try to follow this nerve. If I'm coming down, it is going below. And then it is wrapping around. So this is your greater auricular nerve. But another nerve is there, which is going along the posterior border only. It is not coming anterior. This is your going anteriorly. But here another tiny nerve is there, which is not. This nerve what is seen here is the greater auricular nerve, is very nicely seen. But here now see from below one nerve is coming. Can you appreciate this? This
Yes,
nerve?
sir. Yes,
This
sir.
nerve will not go anteriorly. This nerve will be remaining here only. See, I'm going above. This nerve is remaining there only, along the posterior border. Can you appreciate that?
Yes, sir.
Can you appreciate that? That is your lesser
Yes.
occipital.
Yes, sir.
And if I'm coming down, this nerve which is wrapping around, which was there anteriorly and now going below it, this is your greater auricular. Is it clear?
Yes,
This
sir.
is your
Thank
greater
you.
auricular.
Yes, sir. Thank you,
And
sir.
if I'm going above, this nerve is your lesser occipital. Clear, na?
Okay, sir. Yes, sir.
Okay, sir. Interscalene, is it difficult to show us now, sir?
Interscalene, you want to see again?
Yes, please.
Okay. So start again. It's very simple. Just remember this one. What is this in the middle of my screen? Home page.
Anterior tubercle.
No, I am asking who wanted to show me again. Please tell
C6.
C6 anterior tubercle. So now if I'm coming down, one nerve root is coming, this one. What is this nerve root?
C6.
C6, very good. And there is another nerve root here. What is this nerve root? This is your C5. It came from above.
C5, yes.
And this was your C6. And if I'm coming down, this is coming C7. Still coming down. What is your C8? So now you see which all these nerves where it is going. This is your anterior scalene. And the muscles are coming all one by one posterior to that. Okay?
Okay. Okay,
So
thank
this
you.
is your middle scalene. So interscalene is your here. In this plane, you have to come here and inject here. That is your interscalene brachial plexus. Okay? Here?
Clear, thank you.
Okay. Anybody wish to see anything in the anterior neck? Anybody wish to see anything in the anterior neck? Okay, now I'm going posterior. So remember the posterior muscle. Most superficial muscle is what?
Trapezius.
Trapezius. If I'm removing the trapezius, what are the muscles there in the midline? Tell. Okay, let me recapitulate the anterior, the 3D anatomy, and then I'll be showing it again. Okay, so can you see the 3D model?
No, sir. No, sir.
Okay. Now?
Yes, sir.
Okay. So let me remove all the artery nerve. And let me put all the muscles. Okay. So most superficial muscle was what? Trapezius. Okay. If I'm removing the trapezius, just close to the midline, very bulky muscles, big muscle is what? This muscle? Semispinalis capitis. If I'm going laterally, this muscle is your splenius capitis. If I'm still going laterally, this muscle is your sternocleidomastoid. Right? So now, if I'm removing this muscle, Then what we'll get? We'll be getting these muscles. Let me splenius capitis also let me remove. So then this is your rectus capitis posterior minor, close to the midline. Rectus capitis posterior minor. Then is your rectus capitis posterior major. Rectus capitis posterior minor is inserted as the C1 and arch of the C1. This is the rectus capitis posterior major is attaching at the level of the C2 spinous process, C2 spinous process. And our area of interest is this muscle. This muscle is your what? This muscle is your the inferior oblique. Inferior oblique muscle. This is your superior oblique muscles. So inferior oblique muscles and the semispinalis capitis will be able to see the greater occipital, lesser occipital, third occipital, and in between we'll be seeing the one artery. Let me put the artery, the nerve, and this thing again. And let me put the blood vessel artery. Okay, so above this muscle, above the C2 lamina, we'll be able to see this inferior oblique muscle, and this is your greater occipital nerve, this is your third occipital nerve, and in between we'll be seeing the one artery also. Okay, remember this muscle layer and remember this. And let me now. Okay, so so ideally the best visibility if we can remove the hairs there in the occiput area, but here it is not possible. So you have to bear with us because here the visibility, the gain might not be that great here, but still we'll be able to appreciate it. Okay, so let me next question. Let me increase the gain a little bit more. So what I told there, let me read it here. So very thin layer of muscle, what was there is your this.
Yes.
This was your trapezius. If I'm going still laterally, you'll be getting the sternocleidomastoid also. Then this is your semispinalis capitis. Semispinalis capitis has a medial fascicles, lateral fascicles. It is a little bit more likely. And then here I'm finding not very nicely seen is your rectus capitis posterior minor, and here is your rectus capitis. Rectus capitis posterior major is a very large one. So understand these are the few layers of the muscle. Trapezius, this was your what?
Semispinalis capitis.
Semispinalis capitis. This was what?
Rectus minor.
Rectus capitis posterior minor. This was your rectus capitis posterior major. Very good. So now again. So very thin layer of the muscle on the top is your, this is your, let me increase again a little more. Okay. So this was your, more you'll be going above, sternocleidomastoid will be more thin. If I'm coming down, it will be little bulkier. See, I'm coming down, the trapezius is little bulkier. If I'm going above, trapezius is very, very thin. So now we can see the, this is your what?
Splenius capitis.
Splenius capitis. And here, this is the rectus capitis posterior major. Here is a very thin, is your rectus capitis posterior minor. Now, if I'm coming down, I'll be searching for the bifid spinous process. This is your bifid spinous process. Okay, there's something projection coming out. This is the spinous process because they turn head on one side. So at this point, I'm coming lateral. Okay, so now we'll be able to see the lamina. This is the lamina of the your C2. So this muscle is your, which muscle? Which lies above the lamina of the C2?
Inferior
Obliquus.
oblique.
Obliquus.
Your oblique. Above that, what muscle will be there? Two muscles are there. One is your rectus capitis posterior major, and above that is your, this is your semispinalis capitis. Above that, very thin layer of the trapezius muscle. So now where shall I search for this artery? I'll be searching artery at this facial plane. No, sorry. So here will be your third occipital, here is your pulsating artery, and here will be your nerve. Let me just try to focus it a little better. And below the semispinalis capitis, this is your semispinalis capitis. If I'm going more laterally, this was your trapezius. Okay, so I'll be searching here. So now here at this level is your nerve. This is your greater occipital nerve. Can I appreciate that now? And here is your pulsating vessel. And here is your third occipital nerve. Can I appreciate the greater occipital nerve? Hyperechoic structures. I'm removing the. Can you? Some artery pulsating, and just lateral to that is the greater occipital nerve, and medial to that is your third occipital nerve. Let me reduce the depth a little bit. Okay, so this is the plane where you have to find it out. And you see how I am holding the probe? I am holding the probe little obliquely, so that you are seeing the inferior rectus in the long axis. Now, if I am coming more laterally, then we'll be able to see the sternocleidomastoid, and just medial to that, we'll be able to find the lesser occipital also in the posterior leg, which, so it starts from the lateral side and then it wraps around. So this muscle is your, what? This muscle is your rectus, sorry, the sternocleidomastoid. This muscle. This was your semispinalis capitis. And no, sorry, this is the splenius capitis. Is the splenius capitis. If I am coming more medially, this is your, this muscle is your, the splenius capitis. This is your, because I am holding the probe little more laterally. And this is your, the splenius capitis. So from the midline, again, this muscle on the screen, this is your semispinalis capitis, this was your trapezius. Now, if I'm coming laterally, the muscle what is appearing is your splenius capitis. So this muscle is your splenius capitis. And this is your sternocleidomastoid. And here you can see the lesser occipital. Okay, so lesser occipital, you find it here. You can see that this is your lesser occipital. Just posterior border of the. Can everybody appreciate the lesser occipital now?
Yes, sir.
Posterior to the sternocleidomastoid muscle. This is your sternocleidomastoid muscle. This is your, which muscle I told you?
The splenius capitis.
Splenius capitis. And this muscle was your, sorry, this muscle was your, which is coming now superficially, splenius capitis. This is your trapezius. This is your sternocleidomastoid, and here is your lesser occipital. Okay, so now I'll be going to the
Sir, how to locate the C2 vertebra?
C2 vertebra is spinous process. C2 vertebra, two things. The most important is that is the first bifid spinous process. So if I'm starting from here, you just go on looking. So some bony projection superficial will be coming. So that is your C2 vertebra is coming. Can you appreciate? At this position, I came lateral.
Okay.
And then seeing the lamina of and at this position, I was making it like this. So here in this facial plane, you have to search. So this was what muscle? This was your splenius capitis. This muscle. This was your semispinous capitis. This was your splenius capitis, and this was your inferior oblique. So I have to search greater occipital nerve in this muscle. And this lamina is the very important landmark. Okay, can I appreciate? If I'm putting it here, here's the spinous process, C2 spinous process. And now I'm coming here, then I can see the lamina much better. And these are the muscle layers. This is the inferior oblique, this is your semispinous capitis, this is your splenius capitis. This is your sternocleidomastoid. And here is your and here is your third occipital. Okay, so now the cervical facet. So cervical facet again. You see the valley, hill, and this is a joint. This is a joint. This is a joint. This is a joint. This is your C2C3 joint. This is your why C2C3 joint? First prominent joint will be C2C3 joint. C1 C2 joint will be much deeper. I'll be showing you again. And for the medial branch, you have to put it neatly here. Okay, again I'm holding it. So the left hand side is the cranial side. So this joint is your C2C3. Why? Because it is coming down deep. So the C1 C2 joint is much deeper, difficult to appreciate there in the ultrasound. So this is the C1 C2 C3. Then C3 C2 3 C3 4, and in between then is your all the joints will be coming down one by one. So heel and valley, heel and valley, heel and valley, heel and valley. And you can see, appreciate the nerve here, and you can see the pulsating blood vessels also here. In the valley, the nerve accompanies the blood vessel. So to do the injection, you can come like this in plane, or you can come out of plane here. But out of plane is always dangerous, particularly in the cervical area. We will not recommend the out of plane injection. Can everybody appreciate it? And see how I'm holding the probe also? Fine?
Yes, sir.
So this is a slope. So this joint, this is your C2C3. Then your respective all other joints. And this is the valley. You have to do that. And you can see the black dot is the blood vessels, and the nerve is hyperechoric nerve. Here? Now you tell what you want to say again. Okay, then series can start.
Okay, sir.
Okay.
Are the size visible, sir? Hello.
Yes, yes, it is visible.
Okay. Good afternoon, everybody. After a nice long class of cervical ultrasound, we'll be discussing some cervical pathologies and intervention. Most of the chapters are covered by sir, such as medial branch block, like how to go for greater occipital nerve blocks and the stellate ganglion block. We'll be revising, and we'll also be talking about when to do these blocks. Okay. So starting with, so these are the topics we'll be talking today. We'll be talking about occipital neuralgia and occipital nerve blocks, as well as third occipital nerve headache and its block, greater auricular nerve block, cervical facetogenic pain and medial branch block, as well as stellate ganglia and cervical radiculopathy, along with selective cervical nerve root block. Okay, starting to today's class, I want to just talk briefly about a patient who came to me a few days back with headache. And since the case was relevant to this class, I just wanted to show this slide and the picture of the ultrasound picture of the patient. So one lady of 40 years came to me in the clinic with headache for last 2 years. She had gone under multiple doctor visits, especially neurologist, ophthalmologist, ENT, and dental surgeons. And she explained that she had a gradual onset of head pain with facial pain for last 2 years. Pain was deep aching in nature with a numerical rating scale of 3 to 9. And there was radiation of pain was from posterior aspect of head to the vertex, and pain also radiated to face, especially eyes, nose, and jaw. That's why she went to multiple doctors, especially ophthalmologists, ENT, and dental surgeons. And the pain aggravated while bending forward and doing household work. And pain relief was there with simple NSAIDs like paracetamol. And she also had a history of migraine. And she says that the migraine headache was completely different from this pain that she's having. And MRI of head was done by the neurologist, and they found there was sinus venous thrombosis, and they thought that it was the cause of headache. But actually, when the patient was examined, basically there was tenderness on both trapezius muscle. Her range of motion of the neck was normal, but on palpation of greater occipital nerve area, it was very tender. And during palpation of this greater occipital nerve area, same type of radiating pain mimicked came to the patient. And we also did the ultrasound examination of the neck as sir has done. And as you can see the picture of ultrasound picture, we in the yellow mark, we could see enlarged greater occipital nerve. So the diagnosis of greater occipital neuralgia with trigeminal-cervical complex was given to the patient, and we basically started with simple non-steroidal anti-inflammatory drug along with muscle relaxant, and sent the patient to physiotherapist for the trapezius stretch and chin tuck exercises. And if the conservative management failed, we have planned to go for ultrasound guided greater occipital nerve block at the level of C2. Okay, so this is with this case, I would like to start today's class. So occipital neuralgia. I'm sure everybody, every one of us has and have had an attack of headache. So not all the headaches are termed as migraine. Sometimes the headache, cause of headache can be cervicogenic origin, especially this occipital neuralgia, or other causes. So if the patients come to clinic with headache, directly migraine diagnosis should not be done. We have to clinically examine, and most of the time it can be the occipital neuralgia. So in occipital neuralgia, patient usually complains of sharp shooting, stabbing, paroxysmal headache, either unilateral or bilateral, and it usually radiates from the back of the head, like shown in the picture, to the vertex, and sometimes to the face, cheek, and even to the jaw area. And usually the pain is over the distribution of greater, lesser, and third occipital nerve. And as shown in the case report also, there is usually tenderness over the involved nerve, which is giving the problem. And sometimes the pain can be radiated to the face, jaw, and cheek, and they may confuse with trigeminal neuralgia. So there is a connection between the trigeminal nucleus and basically C1 to C3, and this is known as trigeminocervical complex. And sometimes this pain in the occipital region can mimic radiate to the face, and it is mainly due to the trigeminocervical connection. So in the picture, in the upper side, you can see radiating pain from the neck and occiput to the vertex and to the front. In the middle picture, you can see the all three nerves, like the third occipital nerve most medially, followed by greater occipital nerve slightly laterally, and most lateral are the lesser occipital nerve and the greater auricular nerve. So sometimes these nerves can get impinged and can cause headache, severe sharp shooting headache. And this can we can mistake this for migraine, and patient can have a difficulty in treating the condition. So coming to the etiology of the occipital neuralgia, mainly the cause is trauma. So trauma, especially the whiplash injury, injury or trauma are the specific cause for occipital neuralgia. Second is tumor arising from back of the head or neck are one of the common cause of occipital neuralgia. And neck problems are also one of the commonest cause of occipital neuralgia, especially in this era. Most of us are using smartphone, tablets, and laptop. While using these smartphone, tablet, and laptop, we tend to flex our neck too much. And it is said that almost an individual will basically flex the head for more than 4 hours a day. So this can cause spasm of the muscle of the neck, especially at the back, trapezius and semispinalis capitis. These muscle spasm can cause impinge the occipital nerve and causes headache. So some post-operative condition, especially the surgery of the back side of the head, can cause occipital neuralgia. Post radiofrequency ablation, especially deafferentiation pain, can cause this condition. Atlanto-occipital joint rheumatoid arthritis and subluxation are also causes of the occipital neuralgia. And occipital nerve entrapment, as well as DRJ, C2 nerve root lesion, and dorsal root ganglia lesions are also common causes of the occipital neuralgia. So occipital nerve blocks are commonly done in these conditions, and these occipital nerve blocks are a very effective tool in treating varieties of headache, including like migraine, occipital neuralgia, or even cluster headaches. So the main goal of occipital nerve block is to relieve acute head pain. And in addition to this, another goal is to terminate the intractable headache cycle, especially if the pharmacotherapy are contraindicated, or if the pharmacotherapy are not working. We can go for these occipital nerve blocks to treat headache as well as migraine. And we can also use these occipital nerve blocks for a transitional therapy to assist weaning of medication, such as sometimes medication induced headache can be one of the cause for headache. So while tapering the drugs which can cause headache, we can give occipital nerve block and then gradually taper the drug to prevent the headache. And the main mechanism of action is like any other nerve block. We are blocking basically the nociceptive afferent fibers, especially coming from C1 to C3 in the posterior part of the neck and cervical region, and as well as this trigeminocervical complex. And this can block the afferent fibers and reduce the headache. So coming to occipital nerve block, occipital nerves, we are basically concerned with greater occipital and lesser occipital, as well as third occipital nerve. Greater occipital nerve, as Sir has nicely demonstrated, and you can also see in this picture, it usually arises from dorsal rami of the dorsal rami of C2 nerve. And once it comes out from this suboccipital area, this nerve wraps around the inferior obliquus muscle, and then it lies in between the semispinalis capitis and inferior obliquus muscle. And thus the ultrasound picture Sir was showing was basically in this area. Okay, and the greater occipital nerve travels within the plane of semispinalis capitis and inferior oblique capitis, and then it finally pierces the semispinalis capitis as well as the trapezius, and then supplies to the posterior part of the head up to the vertex. So this is the normal anatomy of the greater occipital nerve. coming to the lesser occipital nerve. This lesser occipital nerve is basically the terminal branch of superficial cervical plexus, and it also has contribution with ventral rami of C2 and 3. So as shown in the picture, this is the superficial cervical complex, and this nerve is the lesser occipital nerve, which usually has connection with ventral rami of C2 and 3, and it ascends upward along the posterior border of sternocleidomastoid. So this is the catch point, as sir has already explained, and as you have seen in the ultrasound picture, these lesser occipital nerves always travel along the posterior border of sternocleidomastoid, whereas greater occipital auricular nerve travels along the belly of the above the belly of the sternocleidomastoid. Okay, so on ultrasound, if you get confused, just see the posterior aspect of the sternocleidomastoid, and the nerve which travels upward along the posterior border is the lesser occipital nerve, and the nerve which travels above the belly of the sternocleidomastoid is a greater auricular nerve. Okay, so another nerve is there which is very important, that is called third occipital nerve, commonly known as TON also. So it is basically an ascending medial branch of dorsal rami of C3 spinal nerve. Okay, and basically it lies medial to the greater occipital nerve, and it supplies to the scalp in the occiput area and the nape of the neck. And as shown in the picture, also it lies within the plane of inferior obliquus capitis and semispinalis capitis. And as you can see in this lower picture, this is basically a medial branch of dorsal rami of C3. And after supplying the C2 and C3 facet, it doesn't supply C1 and C2 facet. In fact, it goes upwards along the muscle plane of inferior obliquus and semispinalis capitis, and it pierces the semispinalis capitis as well as the trapezius, like shown in this picture, and supplies the nape of the neck and occiput area, most lower part of the occiput area, and this can be one of the cause of the headache as well. So there are various indications for greater occipital nerve block. This greater occipital nerve block is not only used for occipital neuralgia, but it can be used for lots of headache conditions, such as it can be used for migraine, to if the drugs are not working and if you want to taper the drugs, we can use in case of migraine. It can also be used for tension type headache, cluster headaches, or chronic daily headache, or even like trigeminal neuralgia if it involves the trigeminocervical complex, and if the posterior aspect of the head pain is there. So these are all our indication for greater occipital nerve block, not only the occipital neuralgia. So any kind of migraine or tension type headache or cluster headache which is radiating to the back of the neck can be used in these conditions. Greater occipital nerve blocks can be used for the relief of pain. And especially if the greater occipital neuralgia is diagnosed, we first manage conservatively with NSAID and physiotherapy. And if the non-steroidal anti-inflammatory drugs and physiotherapy are not working, then only we'll go for occipital nerve blocks. So occipital nerve blocks, traditionally blind technique was used, like shown in the picture. So one imaginary line used to be drawn from occiput to the mastoid process, and depending upon which nerve to target, if we inject in between the medial 1/3 and lateral 2/3, this is basically a site for greater occipital nerve. Or if you want to inject between the at the junction between medial 2/3 and lateral 1/3, it is basically the site for lesser occipital nerve. So this was a blind technique that was used in past, but nowadays we are using ultrasound for accurately blocking these nerves. Okay, like sir has shown in this picture, now we are blocking the greater occipital nerve as well as the third occipital nerve, sometimes at the plane between, at the level of C2, and basically in between the obliquus capitis inferior muscle and semispinalis capitis. So as you already known, to block this nerve, the position of the patient is usually prone with neck flex, and we usually use high frequency linear plow. And we to scan the greater occipital nerve, we start with occiput occipital protuberance, and gradually the probe is moved caudally to see the curved to basically bifid spinous process of C2 vertebra. And once we get the bifid spinous process of C2 vertebra, then we usually tilt the transducer so that one end of the transducer is at the level of bifid transverse process, and another spinous process, and another end, that is lateral end of the transducer, is directed more cranially, so that the probe is along the long axis of obliquus inferior capitis muscle. And in this area, we can see a hypoechoic round structure. Normally, the inferior obliquus capitis muscle is seen as a boat-shaped structure, which is lying over the lamina of C2 vertebrae. And in between this inferior obliquus capitis and semispinalis capitis, we can appreciate oval hypoechoic structure, normally 2 to 3 centimeter lateral to C2 spinous process. And in this area, we can direct the needle in a in-plane direction from lateral to medial side to block the greater occipital nerve. So this is the picture how to scan the greater occipital nerve. Sir has already shown very nicely. We start from the occiput and we basically slide the probe more caudally. And then once we get the bifid spinous process, we orient the probe. So we basically turn the probe, lateral aspect of the probe, to the more cranial side, so that the transducer or probe is along the long axis of this inferior obliquus capitis. And at this area, we can see two nerves as shown in the picture. One is the lateral most part is the greater occipital nerve, and the medial most part is the third occipital nerve. And in this area, we can inject in a long axis. So this is another picture. We are starting from occipital protuberance. We are gradually sliding this transducer more caudally, and once we get this bifid spinous process, we orient the probe so that it lies along the long axis of inferior obliquus muscles. Okay, so in this plane we can see this is the boat-shaped inferior obliquus muscle lying over the lamina of C2, and in between the semispinalis capitis muscle and inferior obliquus capitis muscle, we can see greater occipital nerve. And in this area, we can go inject in an in-plane direction from lateral to medial side to block the greater occipital nerve. So these are some of the pictures of pathology involving the greater occipital nerve. You can appreciate the upper left side. You can see the nerve is swollen. Okay, so this is the entrapped greater occipital nerve in between the inferior obliquus capitis and semispinalis capitis. In the lower part also, this is the lower left side is a normal slide. And if you go to the right lower side, you can see the enlarged greater occipital nerve within the substance of the semispinalis capitis. So this is the impingement of the greater occipital nerve at the level of semispinalis capitis. So these are the few pathological pictures of this greater occipital nerve getting entrapped. And in this condition, we can go in plane and inject from lateral to medial side. Okay, we can use color Doppler here also to prevent injection to the artery. And you can also appreciate if we go beyond this inferior obliquus capitis muscle, vertebral artery is just below it. So we have to be careful of vertebral artery injection even from behind. Okay, we can see the greater vertebral artery just below the inferior obliquus muscle. So it is not that only injection in anterior aspect of the neck we have to be careful of vertebral artery, but injection in the posterior aspect of the neck, because we can easily go through this inferior obliquus muscle and reach the vertebral artery behind. So be very careful while injecting at the neck. Okay. So second is lesser occipital nerve block. So in lesser occipital nerve block, as shown by sir, the patient's position is we can go for the lateral decubitus with the painful area in the upper part. We are using high frequency linear probe, And basically we put the probe just over the sternocleidomastoid, below the mastoid process. And if we scan the probe above and below, we can appreciate a oval hypoechoic structure just posterior to the sternocleidomastoid. So this is the lesser occipital nerve. And if the patient is complaining of lesser occipital neuralgia, or if there is tenderness in the lesser occipital nerve area, we can block this nerve at this site, just posterior to the sternocleidomastoid, this hypoechoic structure, which is shown with the white color arrow. So this is the area of the lesser occipital nerve, and we can block the nerve in this area. So now coming to the third occipital nerve. So third occipital nerve is one of the common cause of headache. And it can so if there is also there is facetogenic pain in especially of C2 and 3, this pain can radiate to the head and cause third occipital neuralgia or third occipital headache. So as soon as described by sir, this basically the third occipital nerve is a medial branch of C3 dorsal ramus, and it is different from other medial branch. Okay, so in other facet joint from C2 3 onwards in the thoracic region as well as lumbar region, this medial branch supplies the facet joint above and below. But this C3 or third occipital nerve doesn't supply two facet joint. It only supplies one facet joint. It supplies C2-3 facet joint, and without supplying to C1-2 facet joint, it ascends upwards, and it lies in between the inferior obliquus capitis and semispinalis capitis, and then it again moves forward. It pierces the semispinalis capitis and supplies the occipital area of the head. And these third occipital neuralgia is common in case of C2-3 facet pathology, or if this third occipital nerve gets entrapped in this area. And it is most common in whiplash injury, as well as it is one of the most common cause of cervicogenic headache. So in case of cervicogenic headache, or in case of this C2-3 facet joint problem, patient usually complains of unilateral pain radiating from C2-3 facet joint and in the suboccipital region. And we can also appreciate tenderness when we palpate this C2-3 facet joint. And in these conditions, we basically inject this third occipital nerve with local anesthetic and steroid. It is always wise to use non-particulate steroid when we are using injecting anything around the neck and above. And if this gives a good pain relief, we can also go for radiofrequency ablation of this third occipital nerve. So this is a picture of the third occipital nerve. As you can see, this there is a wave-like structure, hyperechoic structure. So this is the hills and valley. So above the hill or above the C2-3 facet lies the this third occipital nerve, and it basically arises from this. This is the median branch of C3, and it travels along and supplies to the C2-3 facet, and it ascends upwards between the inferior obliquus and semispinalis capitis. So this is the area to block the third occipital nerve. As you can see, the needle direction is from caudal to cranial side, and basically the target is the upper part of the facet, which basically is the site for third occipital nerve. So how to get this third occipital nerve? We basically place the patient in lateral decubitus with painful site in upward position, and we are using high frequency linear probe. And first we basically put the probe just below the mastoid process in short axis view. Then we gradually move our probe more caudally. Okay, and we first once we move the probe more caudally, first thing that we can see is the C1. or the atlas and the lateral mass of axis. And if we further move our probe downward or caudally, we can appreciate about the vertebral artery appearing. And if we further move our probe downwards, we can see the vertebral artery disappearing and going inside the transverse foramen of the C2 vertebra. And in this place, if we turn the probe in the longitudinal direction, then we can see the C2-3 facet joint. Or another way is, as sir has described, just put your probe laterally along the long axis, at the lateral aspect of the neck. And if we go further upwards, we can see a sudden the sloping of the C2 lamina. And as described by sir, it is very difficult to get the C1, C2 facet. So the first the hump or first heel that appears along the long axis of the neck in the lateral aspect is a C2-3 facet. And just above the C2-3 facet is the location for third occipital nerve. And in this plane, we can target our needle from caudal to cranial direction and deposit the drug after using the collar Doppler and avoid the blood vessels. So another nerve that can cause headache is greater auricular nerve, which is also known as GAN. So greater auricular nerve block is used for greater auricular neuralgia. It can be also used in case of pain due to herpes zoster involving the area supplied by greater auricular nerve. So greater auricular nerve is usually it is a branch of this cervical plexus, and it arises from ventral rami of C2 and C3 spinal segment. And after penetrating the fascia of the lateral aspect of the neck, then it basically curves around the sternocleidomastoid and it moves upward along the belly of the sternocleidomastoid and basically supplies to the ear, it supplies to the external auditory canal, angle of jaw, and parotid gland. So if there is any herpes zoster infection or pain in this area, we can easily use ultrasound to block the greater auricular nerve. So as shown in the picture also, the site of block of greater auricular nerve is the patient position is usually supine, or we can also put the patient in lateral decubitus. We have to put the high frequency linear probe just over the sternocleidomastoid and basically scan the probe above and below. We can appreciate an oval hypoechoic structure above the belly of the sternocleidomastoid muscle. So that is the greater auricular nerve, and we can inject the drug either in plane or out of plane around the greater auricular nerve to block this nerve. Okay, so this is the picture of this is the sternocleidomastoid. You can see nicely, and above the sternocleidomastoid muscle, you can see hypoechoic structure. This is the greater auricular nerve, and this is the position of the probe, high frequency linear probe. Here the injection is done in out of plane, but we can go for in plane injection also. Injecting around 3 to 5 ml of local anesthetic with steroid around the greater auricular nerve will block the greater auricular nerve. Okay, so now coming to the cervical facet syndrome. So cervical facet problem is also one of the common problem of unilateral neck pain, but we have to understand that in the cervical facet pain syndrome, pain may radiate to the shoulder, but it doesn't radiate up to the arm. Okay, so if the patient is complaining of unilateral or bilateral neck pain, especially lateral aspect, and if the radiation of the pain is not beyond the shoulder joint, then cervical facet syndrome can be one of the cause. And during physical examination, we always have to do full neurological examination of the upper extremities to exclude cervical radiculopathy. And as shown in this picture, so this is the painful area of the C2-3 facet pain is usually appreciated in the lateral aspect of the head in the near the occiput. C3-4 facet joint pain is usually in the lateral aspect of the neck and upper part of the shoulder. C4-5 usually involves the lower part of the neck and upper part of the shoulder. C5-6 usually involves the over the trapezius, and C6-7 usually involves the upper lateral aspect of the shoulder as well as in between two scapular line. So these are the painful area in case of facet joint problem. And if the patient comes with pain in this area, we have to think of cervical facet joint pain. And in this, we have to do the palpation of the cervical facet. And in these conditions, if you palpate the cervical facet, this can be tender, where the pathology is. And we can also do range of motion to see whether there is tenderness or not. Normally, when we do the range of motion, if we are checking the facet joint problem in the upper part of the cervical region, we usually rotate the neck with neck flexion. So if we flex the neck and rotate the head, so this test is for the upper facet, upper cervical facet. And range of motion with neck extension and rotation of the neck is for the lower facet joint. So, and these rotation of the neck can be painful in this condition. We can also appreciate tenderness over the facet joint, and we can always order plain X-ray of the C-spine, AP, and lateral view to see any degenerative changes in the spine and facet joint. So these are the way of examining the cervical facet joint syndrome. And in the cervical facet joint syndrome, we usually don't go intra-articular injection like in lumbar area. In lumbar area, we usually, in a facet joint pain in facet joint, we can go and give intra-articular injection in the lumbar area. But in thoracic region as well and in cervical region, we usually block the median branch which supplies the facet. And another reason for not going intra-articular injection in the facet joint is basically it is one main thing is that it is technically difficult, and second is it is dangerous also. So a small volume of the drug into the facet joint can cause stretching and tear of the joint capsule in the cervical region. And another is, since the facet joint in the cervical region is more horizontal, in lumbar area the facet joint is about 45° to 60° in angle, but in the cervical region the facet joint are almost horizontal, or more or less horizontal. So if we inject if we put the needle into the facet joint, it can easily go through and through the facet joint and cause injury to the vertebral artery or to the spinal cord. So as you can see, this is the facet joint, and you can see it is almost horizontal. Okay, so injection to the facet joint can go through and through, and we can go to the we can inject in the vertebral artery, or it can go through and through to the facet joint and injure the this spinal cord. So instead of going into the facet joint, we are basically blocking the medial branch which supplies to the facet joint. Okay, so how to inject and how to get the this medial branch. So here also the position of the patient is lateral with painful side upwards. We can also put a pillow over the head so that the cervical spine is straight, and we always use high frequency linear probe. And we basically identify C2-3 facet. And once we identify C2-3 facet as described above, and we can gradually move our probe downwards and to the level of facet joint we are having problem, and we have to inject the medial branch or block the medial branch above and below the facet joint which is causing problem. So in this picture you can see C3-4 facet joint, C4-5 facet joint. So if the pathology is in the C4-5 facet joint and this facet joint is tender, we have to block the medial branch of C4 as well as medial branch of C5. Okay, and it is always wise to use collar Doppler while injecting anything in the neck, and use a non-particulate steroid. So here also, as seen, the upper part is heel and the lower part is valley. So heel basically represents joint, and this lower part usually represents articular pillar where the medial branch lies. So here heel is basically joint, facet joint, and the lower part or valley is basically the articular pillar where there is location of the medial branch. So coming to the stellate ganglia block. So stellate ganglia block are also very much commonly used in pain practice, And mainly this stellate ganglia block is done when we want to block the sympathetically mediated pain of head, neck, and upper extremities. And as we know that sympathetic fibers of the head and neck is usually supplied from T1 to T3 spinal segment, and the sympathetic fibers for the upper limb comes from T2 to T8 spinal segment. The sympathetic fibers from these levels travel up and merge with the sympathetic chain of superior, middle, and inferior cervical ganglia and supplies to the head, neck, as well as upper extremities. So if there is any sympathetically mediated pain, especially CRPS of the upper limb, or sympathetically mediated pain of the face and neck, then we go for the stellate ganglia block. And as you can see in this picture, as well as in ultrasound, you have already seen. So this is the neck. We usually put the probe in the anterior lateral aspect of the neck and see there are lots of vital structure around there. Vertebral artery is just behind this longus colli. Carotid artery and internal jugular vein is right in front and lateral to the stellate ganglia. Medial to this is the trachea, thyroid, as well as esophagus. So there are lots of vital structure, and inferior thyroid artery is right over here. So previously, classically, this stellate ganglia block was done in a blind technique, and there was reporting of lots of adverse effect while using this blind technique or use of fluoroscopic guided technique. But to avoid this, now we are using ultrasound guided stellate ganglion block, because mainly with the ultrasound we can easily see the vascular structure around the stellate ganglia and block the stellate ganglia much more easily at C6 level as well as in C7 level. Okay, so stellate ganglia, so stellate means star shaped, so that's how it got its name. So it is a star shaped ganglia, which is basically formed by the fusion of inferior cervical and upper first thoracic ganglia, and it is of large size. The length is about 2.5 centimeter, breadth is about 1 centimeter, and thickness is about 0.5 centimeter. And this stellate ganglia lies just in front of the neck of first rib, as well as it is anterior lateral to the longus colli, it is medial to the scalene muscle, and it is posterior to the vertebral artery as well as carotid sheath, enclosing the carotid artery, internal jugular vein, and vagus nerve. So this is the location of the stellate ganglia: anterior lateral to the longus colli muscle, posterior to the carotid, and just anterior to the neck of the first rib. So ideally, we use ultrasound to first identify the C6 vertebra, and then we can inject in this level, giving large volume of drug, or we can even go down and block at the level of C7 and block the stellate ganglia. So basically the recommended technique for stellate ganglia block with the ultrasound is the position of the patient is supine with neck extended and slightly turned to the opposite side where the block is to be given. And we usually use high frequency linear probe as shown in this picture. And we usually start with our home base, that is C6 transverse process, that is Casinax tubercle. And if we put our probe just over the cricoid cartilage, we can appreciate a very prominent anterior tubercle of the C6 transverse process. This is Casinax tubercle, and we can also this is also known as double hump camel sign. So the camel has got two humps. So the anterior hump is the anterior tubercle and posterior hump is posterior tubercle, and in between these two hump lies the nerve root. So first we put our probe and at the anterior lateral aspect of the neck and appreciate the C6 transverse process or Casinax tubercle, and then we gradually we can inject at this level just anterior to the longus colli muscle, or we can go downwards and inject at the level of C7 vertebral level. Basically, C6 transverse process is used mainly because in 90% of the cases, the vertebral artery goes into the foramen in this level. But there are cases, in 10% of cases, the vertebral artery enters into the foramen at the level of C5 and C4. So you have to be very careful, okay, to get the Casinax flaccid tubercle. It is not normally in 90% of cases at the level of C6, the vertebral artery goes into the foramen, but in 10% of cases, in 10% of cases, the vertebral artery can travel up and go into the C5 or C4 level. And here we have to be careful of inferior thyroid artery, carotid artery, internal jugular vein, and we have to use color Doppler while injecting and to get the needle trajectory pathway. And while using ultrasound, the needling is done, usually the injection is done in an in-plane manner, and our tip of the needle should be just in front of longus colli muscle and above the fascia, investing the longus colli muscle, and deep to the prevertebral fascia and carotid artery fascia. Okay, so this is the picture of the position of the probe at the level of C6 and slightly below the level of C6. And you can appreciate the carotid artery in the middle part of the picture. Carotid artery, this longus colli muscle or longus capitis muscle just at the tip of the anterior tubercle of C6 vertebra. And you can also appreciate the internal jugular vein that is collapsed, and in between the carotid artery and internal jugular vein you can see a vagus nerve, and below the vagus nerve and above this longus colli muscle is the location of the stellate ganglia. We can inject this drug from in plane from lateral to medial side and deposit the drug just over the longus colli muscle, anterior lateral to the longus colli muscle, especially 8 to 10 ml of drug. Or we can direct the probe more caudally and inject at the level of C7. It is always wise to use C6 level because it is safe, and in 90% cases the vertebral artery is usually goes into the foramen at this level. Okay, so but we can block at C7 level also. Here is also a picture of the blockage of the needle trajectory for the blockage of the stellate ganglia. And this is the ultrasonography picture with color Doppler, which shows the carotid artery as well as inferior thyroid vessels. So these vessels, we should be aware of these vessels, and we should puncture these vessels, but we should not inject within these we should not inject inside these vessels. So this is another picture of the stellate location of the stellate ganglia, but at the level of C7 level. Here you can appreciate in the lateral side trachea, more medial to it is a esophagus and thyroid, and this is the body of C7 cervical vertebra, and above to this is the longus colli muscle, and above to longus colli muscle is carotid artery. So injection should be done below the carotid artery and above the longus colli muscle, just above the longus colli muscle. And you should be aware of the vertebral artery. Here you can appreciate vertebral artery at the lateral most aspect of this picture. So here the vertebral artery is outside the foramen. Okay, so this is another picture using a color Doppler. Here you can easily see color Doppler taking carotid artery, the inferior thyroid artery. We can also appreciate this vertebral artery and vertebral vein, and this is the longus colli muscle. So if you want to inject in this C7 level, be aware of all these vessels. So color Doppler should always be used for injecting anything at the level of the C7 or C6 level, just to avoid injection to these vessels. Okay. So coming to the selective cervical nerve root block. So this is the cervical nerve root impingement is patient coming for neck pain, which is radiating to hand, usually comes to pain clinic quite often, and we can basically patient comes with pain in shooting, burning, tingling, with numbness, which radiates from the shoulder to the upper extremities, and sometimes it can go up to the fingers also. So this can be a clinical presentation of patient with cervical nerve root impingement at the level of neck, and usually the incidence or prevalence is quite high. In 1 out of 1,000 population experiences cervical nerve root compression once in their lifetime. So in this condition, we can use the cervical nerve root block to relieve pain in these conditions. Okay, so this is the typical presentation of the patient with the cervical nerve root irritation or impingement. So if the C5 nerve root impingement is there, patient will experience pain in the trapezius, in the upper back, as well as this pain can radiate up to the elbow. If the impingement is at the level of C6, then the radicular pain will extend up to the thumb and index finger. If the impingement is at the level of C7, then the pain can travel along the upper and lower arm up to the fingers. And if it is C8, then it usually involves the little fingers and ring fingers, and it radiates from the arm and forearm. So these are the typical pain radiation in patient with cervical radiculopathy. And in these conditions also we can use ultrasound and block the cervical nerve root to alleviate pain. Okay, so normally in case of cervical radiculopathy, we all know that in 80% of the cases it will resolve spontaneously even with conservative management of 6 to 8 weeks. And within these 6 to 8 weeks, we can go for exercise, lifestyle modification, we can go for analgesic and co-analgesic. So if the pain score is too high, or if the patient is not relieved with conservative management, we usually go for injection treatment. And previously, classical cervical epidural was commonly used, but nowadays we are also using cervical selective nerve block to prevent pain in case of cervical radiculopathy. So and we can also go for surgery, but with surgery the complication is about 4%, as demonstrated by a study by Bone and Joint Decade Task Force. So they have said that complication with surgery in cervical area surgery is 4%, but with complication with cervical classical cervical epidural and cervical selective nerve block is about 1%. So in this condition, if the patient we can go for the cervical nerve block, selective cervical nerve block, or even cervical epidural anesthesia, epidural steroid injection to relieve cervical radicular pain. And we have to understand that unlike in lumbar area, where the cervical spinal nerve, basically there is some difference in the location of the cervical spinal nerve root. Okay, in lumbar area, basically this lumbar spinal nerve exits from the foramen from the lower part of the foramen, from the lower part of the vertebral body, but the location of the lumbar this nerve are in the upper part of the foramen. But in cervical region, the cervical spinal nerves are located in the lower part of the foramen. So while injecting in this cervical foramen, we have to be careful that in the lower part of the cervical foramen is the location of the nerve, and the upper part of the foramen is the location of the epiradicular vein. So while injecting, we always have to be careful of inadvertent injection to the various vascular structure and complication. So always advise to use color Doppler, and if possible use fluoroscope hybrid technique of fluoroscope, use dye and inject drug into this area, and always use non-particulate steroid while injecting in this area. Okay, so traditionally, as I've told, traditionally even cervical transforaminal injection was also used in past, but nowadays because of lots of adverse effect, these traditional cervical transforaminal injections are not used. There has been reported adverse effect even with use of the dye. Okay, even with use of contrast agent in this neck region, there has been multiple incidents of intra-arterial injection with fatal complication. So nowadays we use either ultrasound or IV technique with ultrasound and fluoroscopy, and block the selective cervical nerve root block is possible with the ultrasound. And this use of ultrasound in this neck structure usually increases the safety, because we can see the vessels with the help of ultrasound, and this has tremendously decreased the incidence of intra-arterial injection in this area. So main use of ultrasound in this neck area is because of excellent visualization of the soft tissue, nerves, as well as vessels. So as you have seen the demonstration of Dr. Gautam Das, you can see excellently various muscles around the neck. We can also see lots of blood vessels, mainly carotid artery, vertebral artery, very nicely using colored Doppler. And we can also appreciate the hypoechoic nerve, especially C5, C6, C7, C8. You can easily appreciate this nerve with the use of ultrasound. So this use of ultrasound has increased the safety in injection of drug around the neck. And we can also use real-time injection. As we inject, we can see the spread of drug around the nerve, and it also allows visualization of various nerve vessels, and it has greatly improved the safety, especially injecting in this nerve area. Okay, so how to go for a selective cervical nerve root injection? Basically, the patient position is lateral decubitus with painful side up. Here also we are using high frequency linear probe, and here also our first, basically our home page is C6. That is at the level of cricoid cartilage. So first we use this high frequency linear probe and put it over the along the short axis of the neck, and first identify the Casinax tubercle, or most prominent tubercle of the anterior tubercle of the transverse process of the cervical vertebra. And once we get this prominent anterior tubercle or Casinax tubercle, we can see the double hump camel sign. So within this double hump camel sign is the location of the nerve. So at the level of C6, we can see the C6 nerve lying in between this double hump camel sign. And if we move our probe above, we can see double hump camel sign of C5 cervical nerve root, and we can also block in this area, and we can proceed forward. And also we can go down and get the C5 at the level of C7 vertebral level. We can appreciate the vertebral artery bounding in front of the transverse process of C7 transverse process, and we can easily identify the C7 nerve root and inject in this area. Okay, but always be careful that sometimes vertebral artery is in front of the C6, this anterior tubercle, which I'll be showing you the picture, and we have to be careful while injecting the drug. And we usually use 22 gauge spinal needle from posterior to anterior aspect along the long axis. Always put colored Doppler, and always use non-particulate steroid while injecting in this area. The volume of drug is very much less, 2 to 3 cc of drug along with steroidism, enough to block the single nerve. Okay, so these are some ultrasound picture of the C6 at the level of C6, and you can see this is the double hump camel sign. You can appreciate the prominent anterior tubercle, which is known as Casinax tubercle. Anterior to the Casinax tubercle is the longus colli muscle, longus capitis muscle also you can see. And in between this cup-like structure or double hump camel sign, you can appreciate the nerve. And the nerve is usually correspond to the vertebral level. So if the vertebral level is C6, then the nerve which is within this cup or double hump is C6 nerve. And this is the trajectory of the needle from behind to in front, and we can inject in this area to block the C6 nerve. Always use colored Doppler. Okay, so in the right side of the picture, as I have told you, always sometimes in 10% of the cases the vertebral artery can be in front of the Casinax tubercle. Okay, so you have to be careful while injecting in this area. So here in this ultrasound picture, so normally in 90% cases it is at the level of C6, the vertebral artery is not seen, but in 10% of cases vertebral artery and vein can be seen in front of the Casinax tubercle. And in this condition also, as you can see, the needle trajectory is from the posterior to anterior side in plane, and the needle tip is just behind the nerve, in between the cup or double hump camel side. So this is the injection of this is the picture of the C7 nerve root at the level of C7 vertebra. As you can appreciate, there is no anterior tubercle, or anterior tubercle is absent or rudimentary. So here you can easily see vertebral artery in front of the cervical 7 spinal nerve root, and this is the transverse posterior tubercle of the transverse process. So if you want to inject and block the C7 nerve root, we come from behind, and along the long axis we put the needle and block the C7 nerve root. Here, always be careful, vertebral artery is outside or exposed, so prevent accidental injury of the vertebral artery by using color Doppler. So this is injection of the C5 nerve root. Okay, so here you can see there is a double hump camel sign is there, but here the anterior tubercle is not as much prominent as it was in C6 level. So most probably this is C5 level. And here also you can see needle coming from behind, and injection of the needle is done just posterior to the C5 nerve root. Okay, so here we can also use hybrid technique. Once you achieve this picture with ultrasound picture, we can also use fluoroscopy and see whether where is my needle and is it safe to inject this area or not. So normally nowadays hybrid technique is also used. We first identify the nerve, and we put the needle under ultrasound within this foramen, just behind the nerve, and we can use fluoroscope, okay, sometimes. And before injecting in the cervical region, after the placement of the needle with using ultrasound, we can take AP and ipsilateral oblique picture of fluoroscope, okay. So normally in AP view, our needle tip should be in between the anterior and medial border of the articular pillar. And in ipsilateral oblique view, our needle tip should be just anterior to the superior articular process. And in this region area, if you give dye, then we can appreciate this dye exiting out along with the nerve root. And we can also appreciate there is no intra-articular injection. And in this condition, we can inject about small volume of local anesthetic with the non-particular steroid and block the selective nerve root block. We can either use ultrasound alone, or we can use hybrid technology. First start with ultrasound and get the nerve root that is to be blocked, and then use fluoroscope to be double sure, to prevent accidental, to be sure where your needle is first, and second, to prevent accidental injury to the vessel by using dye. Okay, so, and always remember, in AP view, the needle tip should be between the medial and lateral border of the articular pillar, at the level where you are blocking the nerve. And in ipsilateral oblique, the needle tip should be just anterior to the superior articular process in the oblique view. So this can we can be double sure, or can increase our safety or increase our confidence while injecting any drug, especially the selective cervical nerve root block. And as described, as told earlier, the volume of drug is very less. For a single nerve, we are using 2 ml of 1% lignocaine as a diagnostic block, and 2 to 3 ml of lignocaine along with dexamethasone 8 milligram for the diagnostic as well as therapeutic block of the selective cervical nerve root block. Okay, thank you very much. Hello, sir.
So thank you, Siris. Very nice presentation. I hope everybody has appreciated. So any questions, if it is there?
So,
Yes.
So this is not related to this topic. If in case we have any queries after the last lecture, so how are we going to proceed for the questions?
Pardon? Can you repeat the question? What are you asking?
Sir, if after the last class, if we have questions regarding all the topics,
Yes.
how can we ask the questions then during the last 15 days, sir?
That time you cannot ask any questions. That time you have to, whatever the questions you are having, you ask today, you are having the last chance on the next day. That's all.
So I'll not be able to attend the
You are
last.
always telling you complete your module on the next 1 week and ask us question before going to the next.
Okay, sir.
So after that, after the next module, that is the last module, the questions link will be available there, and you have to answer that. You have to click on that question link, and you'll be getting all the questions there. Okay, so start reading next 1 week. Next week, only we'll be having the any question answer sessions.
I'll not be able to join the next session because my son is having surgery. So I'll have to.
Okay, then you have to see the recorded lectures. After that, 2 weeks you'll be getting 2 weeks time for completing the questions. Sorry, giving the exam. Okay, thank you very much.
Sir,
And great.
Sir, one more doubt, sir.
Yes,
Could you,
yes.
in the schedule, the lumbar area is not covered, sir.
I told our last day. Was you not there?
No, no, sir.
That-
Was
that-
not there. At the end, I was not there.
Yes, the lumbar area will be covered next. Next area this was by a typing mistake. This
Okay.
next class is not just thoracic area. It is thoracic and the lumbar area. Okay.
Okay.
Okay. So good night.
Right, sir.